Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. In this short lecture, I would like to highlight to you some new information to the clinicians regarding the management of cases of polycystic ovarian disease. Actually, on 15th of August 2023, the International Organization evidence-based group, which is mastered by an Australian group, supported by SRM and ISHRI and other societies, published new recommendations, updating the previous recommendations in the year 2018. After 5 years of research and publications on polycystic ovarian disease, and 5 years of refinement of the studies and re-evaluation of the evidence and assessment of 17 evidence-based and 54 consensus recommendations and 123 practice points, this group published new modifications and new recommendations regarding the PCOS. The aim was to promote consistent evidence-based care and improve the experience and health outcome in PCOS. Actually, the results of this extensive research and evidence found that the evidence was of low to moderate quality. So they recommended more research and more refinement and modifications. What are the important clinical applications of the 2023 international guidelines regarding assessment and management of PCOS? Actually, the most important modification is the revised diagnostic criteria of PCOS. This is old diagnostic assessment criteria by the same group regarding PCOS, which includes irregular cycles, ovulatory dysfunction, biochemical hyperandrogenism, clinical hyperandrogenism, ultrasound, and so on. And actually, the previous 2018 international evidence-based guidelines relied on diagnosis of PCOS based on either clinical or biochemical hyperandrogenism plus irregular cycles or ovulatory dysfunction, or ultrasound, PCO morphology. The previous recommendation is to rely on 2 of these 3 criteria. Now, due to the overuse of ultrasound, the recent 2023 recommendations mention that you have to rely on the clinical or biochemical hyperandrogenism plus ovulatory dysfunction. If these 2 criteria are present, this is a simplified diagnosis and you have to cancel ultrasound. Okay, this is a number 1 of the modifications. Number 2, you can replace ultrasound morphology by AMH rise in adults only. This is another important modification. The previous 2018 recommendations did not include AMH and underestimated its role in the diagnosis of PCOS. But the recent 2023 recommendations highlighted the importance of AMH in adults as it can replace the morphology of ultrasound for the diagnosis. If you find one of the previous 2, which are clinical or biochemical hyperandrogenism and irregular cycles or ovulatory dysfunction. So you can rely on clinical biochemical hyperandrogenism plus ovulatory dysfunction only, or if one only is present, you can replace ultrasound by AMH in adults. The important modifications regarding diagnostic issues for PCOS in adolescent, that you don't have to order AMH in this age group, as AMH is not valuable in this age. This is another important modification And it is the ultrasound actually is not recommended for this age group as it shows poor specificity. So these are the main modifications and actually the main recommendations of the whole guidelines, importantly to be put in the mind of any clinician, that you have to rely on the clinical findings of your patient of irregular cycles or ovulatory dysfunction in cases of infertility, plus clinical hyperandrogenism. This is sufficient to diagnose PCOS. If not clinically manifest, you can rely on biochemical hyperandrogenism to complete the diagnosis. Ultrasound findings are not essential for the diagnosis, and they can be replaced by MH in adults. And MH in adults high in PCOS, as found in this study, to be more than 3.9 nanogram per milliliter. And you have to exclude other causes of hyperandrogenism like thyroid, like late onset congenital adrenal hyperplasia by 17 hydroxyprogesterone, hyperprolactinemia, and less common causes. And you have to order for pregnancy test, beta HCG, for any patient with PCOS, as they have irregular cycles and unintentional diagnosis and unnoticed pregnancy can be missed by you. You can exclude hypothalamic amenorrhea by low or normal FSH and LH with low estradiol, primary ovarian failure, low estradiol, high FSH and LH, androgen secreting tumors, or Cushing syndrome. These are other causes that should be excluded in cases of hyperandrogenism. The second important issue of the recent recommendations 2023 is this algorithm or this table, which shows step 1, you have a patient with irregular cycles or ovulatory dysfunction, infertile with ovulatory dysfunction, plus clinical hyperandrogenism. This is sufficient, okay? You can diagnose PCOS. But if no clinical hyperandrogenism, you can test for laboratory or biochemical hyperandrogenism. If present, this is sufficient for the diagnosis. If not present, only one irregular cycles or ovulatory dysfunction or hyperandrogenism, not together, you can do ultrasound in adults only. But if positive, okay, this is diagnosis of PCOS. For adolescents, don't rely on ultrasound for the diagnosis. And actually, the diagnosis, the recommendations highlighted the importance of MH, as it should not be used as a single test. You should not rely on MH alone for diagnosis. You have a patient with irregular cycles or infertile with ovulatory dysfunction, plus hyperandrogenism or subclinical hyperandrogenism, you can order for MH for completion of diagnosis. It is adjuvant for the diagnosis, not a sole diagnostic item for PCOS, and should only be used in accordance with diagnostic algorithm previously mentioned. And inclusion of MH is only for adults, not for adolescents. And you have to put in mind the factors that may influence MH, like age, as it has a peak between 20 and 25 years, body mass index, increased body mass index lowers MH, hormonal contraceptive and ovarian surgery have impact on the MH level, and also menstrual cycle. They may vary according to the menstruation, and this is a new information getting from this recommendation that the serum MH may vary across the menstrual cycle. This is the 2018 recommendation regarding ultrasound not to be done less than 8 years after menarche, because the diagnosis may be mistaken by multifollicular ovaries, and more than 8 years after menarche can be used using some precautions in the previous recommendations, like 8 megahertz and at least 20 follicles in at least single ovary, and ovarian volume more than 10 millimeter. The recent 2023 recommendation mentions that there is no definite criteria to define PCOM in adolescents. That's why they ignored the use of ultrasound in the adolescents. And also they mentioned some regulations regarding ultrasound because the previous recommendation, 2018, mentions that PCOM is not necessary for diagnosis. However, it will identify the complete PCO phenotype, which means it is an adjuvant and complementary to the clinical or biochemical hyperandrogenism plus clinical presentations. The recent recommendations, 2023, mentions that follicle number per ovary is the most effective ultrasound marker. Follicle number per ovary, follicle number per cross-section, and ovarian volume should be considered accurate diagnostic markers based on other studies. Follicle number per ovary of 20 in at least one ovary should be considered the threshold of PCOM in adults. All these are studies evaluated by the group and found these are the conclusions. And you have to, when you are reporting on the ultrasound, you have to consider last menstrual, you have to write last menstrual period, the transducer bandwidth, frequency, approach, total number of follicles per ovary, measurements in 3 dimensions to assess the volume and other ovarian problems. And you have to exclude the dominant follicles from ovarian volume, and you have to rely on the other ovary if there is a dominant follicle in one ovary. And lastly, you should comment on uterine features. This is the most important modification of the international guidelines regarding assessment and management of PCOS. Second point is early PCOS detection in adolescent. And actually it is highlighted, just highlighted, that you have to make early diagnosis of PCOS in adolescent, because PCOS is a long life disease. And when you diagnose it in the adolescency, you can advise your patient to avoid the long-term complications and long-term outcomes. And I mentioned a lot of the precautions and diagnostic issues of adolescent PCOS and how to manage in this channel, on this in this lecture, in this channel. The third recommendation is tailored treatment plans, which means that the treatment should be personalized or individualized according to precision medicine, according to patient's symptoms, medical history, and preference. And lifestyle is an important issue in all PCOS management, including diet control, exercise, weight management. I think all of you are practicing this advice to your patients, and this is a first line. Pharmacological innovations, recent advances in pharmacological treatments are encouraged, and novel medications are encouraged, but without sufficient evidence. COCs are considered first-line pharmacological treatment of menstrual irregularities, but not for infertile women. And for hyperandrogenism, there is no specific recommendation regarding the type of preparation, but you have to use the least androgenic preparations and least estradiol content. Regarding hirsutism, may be manifest clinically, maybe minimal or subclinical, not clinically seen. And in such a case, you have to rely on biochemical assessment, measuring free testosterone and total testosterone. And the management highlighted in these recommendations that mechanical laser therapy is effective for hair reduction. Anti-androgens are of limited rule, but if you use spironolactone of 25 to 100 milligrams per day, appears to have the lowest risk of adverse effects. Others, like cyproterone acetate, of a dose of more than 10 milligrams is not advised due to the some risks like meningioma. Other types may have some increased liver toxicity. So if you give anti-androgens, you have to stress on spironolactone as one of the safest. Regarding infertility cases, you have to highlight the infertility management plan, and this algorithm has been recently published. I put to you the 2018 and 2023 algorithms, and you can find both of them are more or less similar. First line is lifestyle modification and diet control, exercise, and so on. And the second is pharmacological. The previous 2018 highlighted the role of letrozole as a first line therapy, sometimes clomiphene plus or minus metformin, or metformin alone, or gonadotropins. The same lines are seen in the recent recommendations, but they highlighted increasing dose of letrozole as a first-line medical treatment, and I'll give you one slide on a recent publication of increasing dose of letrozole. This is the recent modification. And also regarding the third line, which is IVF, they added it. You can offer your patient IVF with potentially with IVM, in vitro maturation. This is a new addition, and single embryo transfer is recommended. These are the new recommendations in the 2023, increasing dose of letrozole, IVM, and single embryo transfer. The increasing dose or increasing duration of the letrozole has been published in this year in some studies, and that's why they added it in the recommendation. Metformin in adults can be given for patients with body mass index more than 25 kilogram per square meter for metabolic control and avoidance of long-term complications of the PCOS, including insulin resistance, glucose, and lipid profile abnormalities. Actually, the maximal dose for adults is 2.5 grams, for adolescents just 2 grams, and we have to monitor vitamin B12. Metformin is not routinely recommended for use in pregnancy, as its long-term effects is unclear so far. You have to inform your patients this information. It's more effective than some other preparations like inositol or caryostol, which offer limited clinical benefit in PCOS, but you can give them because they are safe, as they mentioned. Other anti-obesity measures like bariatric surgery, yes, you can offer your patient bariatric surgery if the BMI is more than 35, and usually bariatric surgery is offered for patients if the BMI is more than 40, but 35 if there is a comorbidity, and PCOS is a comorbidity. Adult anti-obesity medications like, importantly, glucagon, like peptide-1 receptor agonist, is a novel or a new modification in addition to orlistat, which and safety during pregnancy is not yet proved. So you can, this is the innovation in the medication for extended letrozole and glucagon like peptide-1 receptor agonist in the treatment. So they highlighted the diagnosis, the lifestyle, the off-label prescription of the drugs. You know that letrozole, metformin, and so these drugs are not in the insert. The use for PCOS is not included, and actually they are considered off-label prescription, but they encourage this off-label use as there is evidence-based studies supporting their use, and particularly metformin and in vitro fertilization. As I told you, they recommended in vitro maturation, but usually in IVF we use freeze-all technique and GnRH triggering, so the risk of ovarian hyperstimulation is minimal. Regarding pregnancy outcome, they mentioned that there is increased risk of higher gestational weight, miscarriage, gestational diabetes, hypertension in pregnancy and preeclampsia, intrauterine growth restriction, small for gestational age, low birth weight, preterm delivery, and C-section. All these are risk factors, potential risk when the PCO patient got pregnant. She has to be monitored meticulously for blood pressure, for oral glucose tolerance tests in the first antenatal care, and should be repeated at 24 to 28 weeks of gestation. Consider cardiometabolic health problems, and this should be highlighted to the patient as a PCOS is a risk factor for insulin resistance, dyslipidemia, cardiovascular, and other diseases. And you have to put in mind some ethnic variations. And insulin resistance is a key feature of PCOS, but unfortunately, the recommendations mention that it is not very valuable due to inaccurate and clinical measurements are not currently recommended. Due to the inaccurate measurements and some problems, they still do not recommend the insulin resistance testing for patients with PCOS. But once you diagnose insulin resistance, you have to you should address the reproductive, metabolic, cardiovascular, dermatologic, sleep, and psychological features of PCOS. In this slide, insulin resistance can be measured by this equation, which is the homocysteine model assessment of insulin resistance, means fasting glucose multiplied by fasting insulin divided on 22.5. And always I mentioned in the previous lectures that HOMA insulin resistance 1, 2, 3. If it is less than 1 normal, more than 3, it is insulin resistance 2, or in between is borderline or early. And this is seen in this lecture on management of non-infertility problems of polycystic ovarian disease in the same channel. Also, the lifelong health plan of the patients to modify his lifestyle, prevention of weight gain, optimizing fertility and preconception risk factors, and prevention and treatment of diverse clinical features, including metabolic risk factors, diabetes, cardiovascular, sleep disorders, which all increase in PCOS. And PCOS should be considered as a high-risk condition. So in any PCOS patient got pregnant, she is a high-risk case liable to these the previously mentioned possible complications, and increased premenopausal risk of endometrial cancer should also be recognized, while absolute risk remains low. You have to put in mind that a PCOS patient has some mental problems, psychological problems, and anxiety, depression, due to change in the body image, impact of her body image on her brain and quality of life, and eating disorders, and claiming by the neighboring or if the husbands that you are obese and you are PCOS and so on. This may have an impact on her mental health, and you have to put in mind that you should manage anxiety, depression, and other emotional challenges, and you can consult a psychiatrician to help you for treating such a case, and some antidepressant treatments or drugs can be given to this patient. Ethnic variations, as I told you, as previously mentioned in the 2018 recommendation, may affect PCOS. You should be very transparent when you are treating such a case. You have to tell the patient about the potential risks and benefits of various treatment options, and you have to highlight the long-term PCOS management approach. Always I say to my patients with PCOS that PCOS is a long life, with a lifelong condition that will persist with you till menopause. So we have to manage this lifelong condition with regular follow-up visits, prevention of possible cardiovascular and metabolic complications, and actually the treatment should be individualized according to the complaint. In conclusion of the 2023 recommendations, that they changed the diagnostic criteria and added the AMH rule in adults and individualization, highlighting non-infertility health problem, low to moderate quality evidence actually is present nowadays, and they asked for more research as recommended in these key updates, and I summarized them to you in the previous slide. Thank you.